Good afternoon and welcome to our lecture on recurrent pregnancy loss and adverse pregnancy outcomes. I'm going to turn the floor over to Dr. Victor Rosenberg, who is our speaker today. If you do have any questions, please feel free to type them into the chat box or unmute your mic at the end of the presentation and ask your question then. Without any further ado, Dr. Rosenberg, please go ahead.
Thank you, Teresa. My name is Dr. Victor Rosenberg, and I am a maternal-fetal medicine physician located in Lawrence, New York, which is on the South Shore of Long Island. The office information is down at the bottom of the screen, and we'll share it at the end. And I welcome you to explore our website and learn more about our practice and the specialty of maternal-fetal medicine. Let me sort of jump right in here, and let's talk about a topic that is very near and dear to me, and one that I see many patients with, and try to give some sort of patient information and patient education via a webinar. And the topic, as Teresa mentioned, is recurrent pregnancy loss and adverse pregnancy outcomes. Let's start with the basics, in that patients sometimes don't even know what maternal-fetal medicine is. And so the question of what is maternal-fetal medicine, it is a subspecialty of obstetrics and gynecology. It's also called high-risk obstetrics. And a maternal-fetal medicine or MFM physician is a physician who has subspecialty training in taking care of patients who currently have a complication in a pregnancy or have had a complication in a previous pregnancy. And the training involves a 4-year residency in regular or general OBGYN, followed by an additional 3 years of fellowship training or additional training in high-risk obstetrics or maternal-fetal medicine to obtain additional knowledge and expertise in caring for patients who are having complications in pregnancies. And we are sort of the go-to pregnancy experts. So let's start with some basic definitions and how do we define an adverse pregnancy outcome? And an adverse pregnancy outcome is defined as a pregnancy that resulted in what I would call a less than perfect outcome. Adverse pregnancy outcomes include really any of the following. They range from recurrent pregnancy loss in the first and the second trimester, and we're going to talk a lot more about these two issues. A fetal demise or a stillbirth in the second and third trimester, and a pregnancy which may have been complicated by either poor fetal growth, what is called placental abruption, or a premature separation of the placenta from the wall of the uterus, which can obviously have untoward effects or negative effects on the baby and the pregnancy, and what is called early onset preeclampsia, which is high blood pressure in pregnancy that occurs early on and therefore leads mostly to trouble with the fetus in terms of prematurity and obviously the mother as well. The reason it's important to determine why a patient had an adverse pregnancy outcome, which is a lot of what I do when I see patients in the office for consultation, is because number one, patients want answers. They want an explanation for what went wrong. And probably even more importantly, other than finding out what went wrong, is these events can recur in a subsequent pregnancy. And therefore, it's really important for us to try to figure out what happened, and therefore, number one, what are the chances of a recurrence, and even more importantly, what can be done to decrease or mitigate the risk in a subsequent pregnancy to allow for a hopefully healthy pregnancy outcome. We talk about causes of pregnancy loss by trimester, and physicians divide pregnancy not into months as patients do, but into really weeks, and a typical pregnancy is 40 weeks in terms of the duration. And we talk about trimesters. The first trimester is typically from the beginning of pregnancy until 12 to 14 weeks. The second trimester is typically from 14 weeks to 28 weeks. And the third trimester is from 28 weeks until the end. And it helps to divide the causes of pregnancy loss by trimester because the causes can be different at the beginning versus the end. So let's talk first about first trimester losses. First trimester losses have many different reasons reported in the literature and what we know. But the most common reason why a pregnancy ends in the first trimester, and certainly pregnancies that end before 10 weeks, is because there is something wrong with what is called the genetic makeup of the pregnancy, which is essentially the programming that takes a sperm and egg and brings it together and therefore forms a baby. Sometimes the genetic makeup is abnormal. And think of it as a sort of computer code, is that if the computer code is broken, the computer program doesn't work. And it's the same with a pregnancy. If the genetic programming to turn the conception into a normal pregnancy is not there, the body actually realizes very early on that the genetic makeup of the pregnancy is abnormal and actually has a miscarriage to get rid of the abnormal pregnancy. And that is by far the most common reason why pregnancies end early on. And we know that from when they do testing on the pregnancies in research studies. And what they find is that the vast majority, 80, 90+% of pregnancies that end early on in the first trimester or less than 10 weeks are because of a genetic abnormality. But there are other causes of pregnancy loss. And these include some maternal conditions that we'll talk more about in just a little bit. But just to give sort of an overview, we talk about thrombophilia or clotting disorders, which is sort of very known out within the community and patients are aware of from reading about it. And we'll talk about that in just a little bit. Maternal disorders such as uncontrolled diabetes can lead to miscarriages. Thyroid disease or uncontrolled thyroid disease can lead to miscarriages. We talk about causes of miscarriages, including uterine abnormalities, where there is something wrong with the shape of the uterus or there is something inside the uterus like a polyp or a fibroid that doesn't allow the pregnancy to implant normally within the uterine cavity. And lastly, we talk about infectious or what are called immunologic reasons for pregnancy loss. And really over the past 10 or 15 years, there's been a lot of research looking at these causes. And for the most part, infections are really not thought to cause first trimester losses. And there's a pretty large field looking at immunology as a cause for miscarriages in the first trimester. And most of those theories, as far as the current medical literature goes, really have not borne out. And then the last one is really what we call an unexplained first trimester loss. And the most important thing to remember here is that unexplained is really what we would call a diagnosis of exclusion, meaning it's not okay to say it's unexplained and not look at all for a reason. But if you look for a reason for the loss and you don't come up with one, then as a diagnosis of exclusion, sometimes we are left with the unexplained category. When we get beyond 14 weeks, or certainly beyond about 12 weeks, we talk about causes of second trimester loss. And there are second trimester losses where there is a fetal demise or there is a heartbeat initially, and then sometime after 14 weeks, the heartbeat stops, and that would be a loss as in a demise in the second trimester. But then there are patients who end up losing pregnancies in the second trimester from another cause. And that cause falls under what we call cervical insufficiency or preterm labor. Cervical insufficiency, which used to be called cervical incompetence, although we've really sort of moved away from that terminology, is simply defined as the cervix is not strong enough to hold a pregnancy. And as the uterus grows, somewhere between 14 and 21 or 22 weeks, the uterus grows, it puts pressure on the cervix, and unfortunately the patient loses the pregnancy due to the cervix not being strong. And then there are patients who go into preterm labor at a point where the fetus or the baby couldn't survive, and they go on to lose the pregnancy from that. And sometimes in those situations, there's an infection that develops within the uterine cavity that contributes to the loss. If we talk about second and third trimester, so really from 14 weeks on, and causes of stillbirth or a fetal demise at that gestational age, again, there are many reported reasons for this to occur. And we break them down into really categories of what we call fetal, maternal, and placental reasons. If we talk about fetal reasons, or there's something wrong with the baby, and that's the reason why the miscarriage occurs in the second or third trimester. Those are oftentimes due to a congenital anomaly, or there's something structurally wrong with the way the baby developed in utero. Chromosomal abnormalities or genetic abnormalities, similar to what we talked about in the first trimester. Growth restriction can lead to a demise in the second and third trimester. Hydrops, which is an abnormal swelling of the baby that we will sometimes see on ultrasound as an explanation for the demise. Metabolic disorders, these are typically inherited disorders that don't allow the baby to develop normally in utero. And again, infection, as we mentioned before. We talk about placental causes of second and third trimester demise, and these include things like abruption, or we mentioned before, a premature separation of the placenta from the wall of the uterus, a cord accident, what we call uteroplacental insufficiency, which we'll talk about more in just a minute, which is in layman's terms, the placenta is not functioning the way that it should. And if the placenta is not functioning the way that it should, the nutrients that need to go from the mother to the baby in order for the baby to grow and develop are not there, and then that leads to a demise. And then a less common cause is what's called a fetal maternal hemorrhage, which is a situation where there is always going to be mixing of fetal and maternal blood during pregnancy. That's how the baby gets the nutrients that it needs from the mother through the blood. But in certain circumstances, and these are pretty uncommon, there is an excessive amount or an extra amount of bleeding from the fetus into the maternal circulation, and that can lead to a demise. And then lastly, we talk about maternal conditions. What if the mother has uncontrolled diabetes or high blood pressure, hypertension, kidney disease, and that could sometimes not allow a pregnancy to develop normally. And then lastly, this category of thrombophilia or clotting disorders, which can be associated with miscarriages in the second or third trimester. Going back to recurrent first trimester losses, how do you define it? Years ago, you had to have had 3 early miscarriages in order to be labeled as having recurrent first trimester miscarriages. That definition has really been moved up over the years to a patient who has 2 or more rather than 3 or more losses. And importantly, from a medical standpoint, it's the correct and right thing to do to start a workup on a patient after 2 losses rather than waiting for that third one. And most patients are relieved to hear that, and that they don't want to wait for a third loss to find out if potentially there's something wrong, which obviously makes sense. And then we can't forget that, yes, there are causes of miscarriages as we're going through, but, and I tell this to patients all the time, that regardless of what we find or what we do, there is a high likelihood of a successful next pregnancy without any testing or intervention. But occasionally we do need to do things differently, either preconception, before the patient gets pregnant, or during pregnancy, in order to allow or help the patient achieve the goal of a healthy pregnancy. So what is the evaluation that we do or that's recommended? And this is again based on years of medical research and science and what's published in well-respected medical journals. And it really is a pretty short list, and one that can really be ordered within one visit in seeing a patient. And this is the typical workup that I'll do, and one that's again recommended by in medical journals, and that is what we call testing for acquired thrombophilia, or what we call antiphospholipid syndrome, which is a clotting disorder that can be associated with recurrent miscarriages, certainly in the first trimester. So we do blood tests in order to test the mother to see if they have this specific condition, and it's again a blood test. We also, remember we mentioned before that the most common reason why miscarriages occur in the first trimester is because of a genetic or chromosome problem within the pregnancy. And occasionally that is something that's coming from one of the parents, whether it's maternal or paternal, whether it's from the mother or the father. And you can actually do a blood test, and this is another test that we order, both on the mother and on the father, to see, or on the patient and her spouse, to see if they have themselves a genetic abnormality, which is potentially causing a miscarriage. And again, that's a blood test that's ordered. The next thing we do, and this goes back to, again, what we mentioned before, which is that occasionally miscarriages occur because the uterine cavity itself is not normal and doesn't allow a pregnancy to develop. And we order what's called a saline sonohystogram, which is an ultrasound looking at the uterus after putting some saline or salt water into the uterus. And this is done typically by a radiologist, where you can look inside the uterus with an ultrasound to make sure that the uterus is normal, or find out potentially that there is something wrong with the uterus that may need to be addressed, typically with some type of surgery to correct that problem. And then lastly is another blood test, and that is a screening blood test for the mother to make sure that she doesn't have diabetes or thyroid disease. And again, we mentioned that sometimes if you have uncontrolled diabetes or thyroid disease, that could lead to miscarriages. So we do additional blood tests to screen for that. And again, this is a typical workup in a patient who I would see in the office who's had recurrent miscarriages, and we would order these tests and obviously talk about the results once they were available. Next, we move on to second trimester losses, and we started talking about this before, which is where you really need to divide second trimester losses into a loss that is a fetal demise, or that there was a heartbeat initially in ultrasound and then the heartbeat went away, or a patient who loses a pregnancy from preterm labor, or what we call cervical insufficiency, or the cervix is not strong enough to hold the pregnancy. And this category of preterm labor cervical insufficiency is really almost sort of a subcategory for all these losses, and the workup is a little bit different. We spend a lot of time, number one, talking to the patient and understanding from their perspective what happened. We ask questions about whether they had contractions, whether they felt anything before they went on to lose the pregnancy. We try to determine whether it was painless cervical dilatation, or painless meaning they weren't having contractions, or were they in preterm labor. And that helps us try to sort out the issue of whether this is preterm labor versus cervical insufficiency. And that's important because the treatment is different, as we'll get to on the next slide. But we spend a lot of time, number one, I spend a lot of time talking to the patient, trying to understand the details surrounding their loss. And some patients have better recollections than others. And then probably even more importantly is we obtain medical records. And we really spend a lot of time, my staff spends a lot of time obtaining records from wherever you delivered it. The hospital doesn't matter. There's always going to be a medical record that's going to describe what happened at the time that you lost the pregnancy. And there's usually a wealth of information in there that will allow us, or will allow me, or a physician to try to determine the reason why the patient went on to lose the pregnancy. Oftentimes when we get those records, we can actually also get ultrasound images that were done at the time that the patient unfortunately lost the pregnancy. And if we have a chance to review those images from the ultrasound, sometimes we will see sort of a classic pattern of what we call cervical insufficiency or cervical shortening within the cervix. And if you look on the slide, this is what would be sort of a normal cervical length. And as the cervix starts to open from the inside, as you move over to the next picture to the right, you see what's called a Y-shaped opening, where this is just amniotic fluid and the cervix starting to change. And then over time, that amniotic sac goes down even actually further into the cervical canal and forms what's called a V-shaped funnel. And then the last step is what's called a U-shaped funnel, where now you have a pretty large opening of the cervix. The bag of water comes down. You're left with just a little bit of cervix over here to keep the pregnancy in. And then unfortunately, the patient goes on to have a pregnancy loss from what is called, again, cervical insufficiency, or the cervix is just not strong enough to hold a pregnancy in. Again, this used to be called cervical incompetence, but we've moved away from that terminology. The way you evaluate patients like that is, number one, you want to be sure that the uterus itself is normal? What if there was something inside the uterus that wasn't allowing the pregnancy to develop? And that's the reason why the patient went on to have the loss. And that's where we do, again, what's called a sonohystogram. We order, again, a sonohystogram to look for uterine structural abnormalities. And this is a schematic or an ultrasound image from a sonohystogram where you see a little catheter inside the uterus. And by instilling a little bit of saline, you could actually look inside the uterine cavity to make sure that what's called the endometrial cavity is normal and that there's nothing abnormal inside. And then we also make sure to get a copy of the placental pathology, if available, to look for evidence of infection or whether there was chronic bleeding during pregnancy, and that sometimes patients have what we describe as a hemorrhagic loss, where they have bleeding that continues pretty much throughout the pregnancy, and then they eventually go on to lose that pregnancy. The reason why it's so important to make an accurate diagnosis of cervical insufficiency is because there actually are effective treatments. And the treatment for that is really what's called a vaginal cerclage or a cerclage, which is really just a suture that keeps the cervix closed and allows the pregnancy to continue. And the schematic is just an image where if this is the baby developing and this is the uterus over here, if the cervix is open, then obviously, as we saw in those ultrasound images before, the patient is at risk for the pregnancy coming out or delivering prematurely. So what the doctor will do is put a cerclage or a stitch into the cervix over here, and that's typically done vaginally as a vaginal approach. It's an outpatient procedure where you'll put a stitch or a suture around the cervix and literally close the cervix down so that the pregnancy can't escape. And allow the patient to continue the pregnancy as opposed to going on to have a pregnancy loss, unfortunately, again. Occasionally, the vaginal cerclage, which is a suture that's placed again through the vagina, doesn't work, and then patients are sometimes referred to have what's called an abdominal cerclage, which is a suture that's even higher up on the cervix and may work a little bit better in some patients in trying to keep the pregnancy in and prevent a patient who has cervical insufficiency from, unfortunately losing another pregnancy. Moving on to patients who go on to have a second or third trimester stillbirth, we talk about the placental pathology, and it's really crucial to try to obtain, certainly by the time you get into the third trimester, 28 weeks and beyond, to obtain the pathology report. And wherever the patient delivers, the vast majority of the time, the doctor who delivers the stillbirth or does surgery to remove the pregnancy from the uterus will send the will send the placenta to a pathologist to evaluate, to try to see if the pathologist can look at the placenta and try to help us determine why the demise occurred. And I'm pretty liberal with sending pathology slides for a second opinion, in that the information that you get from the pathology is really only as good as the pathologist who interprets it. And there are really some phenomenal placental pathologists out there who can help us, and we can arrange for slides to be sent from any hospital or facility where a patient delivers for a sort of specialized placental pathologist to look at placental slides and try to help us sort of put the story together as to why the demise occurred. A pathologist will look for evidence of infection, uteroplacental insufficiency, or the placenta wasn't working the way that it should and providing the nutrients that it should to the baby, evidence of abruption on the pathology, which is a premature separation of the placenta, and again, that fetal maternal hemorrhage we talked about before, which is an excessive amount of blood from the fetus or the baby going into the mother's circulation. I want to finish up by sort of addressing the issues of clotting disorders, and that there's a lot of information out there for patients regarding clotting disorders and their association with really pregnancy loss across all 3 trimesters. And clotting disorders get divided up into what are called acquired thrombophilias, which is something that a patient develops over time, and a genetic or inherited clotting disorder. If you talk about acquired thrombophilia, that is essentially another word for antiphospholipid syndrome, which is a very well-defined rheumatologic condition that maternal fetal medicine physicians are also very familiar with, and can lead to pregnancy complications. The antiphospholipid syndrome was defined by what are called the Sapporo criteria, which were published in 2006, and the criteria really haven't changed since then. And they include the patient needs to have a clinical suggestion or a clinical criteria for this specific syndrome, and it includes things like pregnancy problems, like multiple losses, stillbirth, or placental dysfunction, a lot of the things we've been talking about, and therefore many patients who are being evaluated for recurrent pregnancy loss or adverse pregnancy outcomes will meet clinical criteria for this disorder. And then we do blood tests to see if they have blood or serologic evidence of this disorder. And those include what are called cardiolipin beta-2 and lupus anticoagulant testing. And again, that's a blood test on the mother to see if the patient herself will meet criteria for this clotting disorder called antiphospholipid syndrome. And if they do, meaning they've had, let's say, multiple miscarriages and their blood tests are abnormal, fortunately, there are treatments that work, and it typically involves giving patients some variation of a blood thinner, including things like Lovenox or aspirin during pregnancy, in order to help the patient go on to have a healthy pregnancy and obviously not have another demise or miscarriage. The next category related to this are what are called inherited thrombophilias, and these include things that are pretty known to patients who've been through miscarriages, and include things like factor V Leiden, the prothrombin gene mutation, protein C, protein S deficiencies, and there are blood tests that are done, oftentimes ordered by OBGYNs or hematologists, looking for these clotting disorders. And the question becomes whether, if a patient tests positive for one of these inherited or genetic clotting disorders, whether that is the cause of the miscarriage. And this has been really studied for the past 20 plus years. And what we know now that we didn't perhaps know in the year 2000 is that most of the literature has shown that in these inherited or genetic clotting disorders like factor V and the prothrombin gene mutation are not associated with first trimester losses. Whether they're associated with later losses is more uncertain, as the medical literature conflicts itself a little bit on that issue. And we really need to individualize treatment in these patients. The treatment, again, is typically with a blood thinner, and I see many patients in the office for consultation to discuss specifically these issues where they've had these tests done, the tests are positive, and maybe they've had a miscarriage or two, and the question of whether these inherited clotting disorders have anything to do or cause the miscarriage. And again, for the most part, within the first trimester, the answer is no. Once you get into the second or third trimester, it becomes a little bit more uncertain, and you need to individualize for obviously each patient. And that's really all I had to go through. I hope that was a helpful overview of the topic of, again, recurrent pregnancy loss, whether it involves the first, second, or even third trimester, and then losses related sometimes to things like cervical insufficiency or preterm labor, which is another reason sometimes patients go on to lose pregnancies. Again, I'm more than happy to answer questions. If not, you're always welcome to go on our website to learn more information about the practice, or call the office, and we're always happy to try to help patients over the phone, and certainly arrange to see patients. We offer telehealth visits as well as in-person visits in our office, and we'd be happy to see you. If there are any questions, please unmute, and I'm happy, or put them up in the chat. If not, we'll end there. And I thank you for joining us, and I hope you found this information helpful and informative.
Thank you very much, Dr. Rosenberg. So we'll just give another 30 seconds or so in case there are any questions. Please feel free to ask. Otherwise, we will wrap it up. And again, thank you for a very informative presentation, and we look forward to additional topics in the future. The replay of this will be available on the website, rosenbergmfm.com, and we look forward to seeing you again. Thank you.
Thank you for joining. Have a good night.